Mute.
All right. Hello, everybody. Thank you for joining us for today's webinar on the reader monitoring plans and the variability in quality control for ADC, immuno-oncology, cancer cell therapy, radiopharmaceutical studies. My name is Gene Kim, Associate Director of Medical Affairs and Innovations at the Merit. For those of you who are attending for the first time, we're delighted to have you join us. And of course, we extend our deepest appreciation to all returning attendees as well. Imaging assessments in a clinical trial, especially those involving oncology, present unique challenges. The various factors involved in an imaging assessment can introduce sources of variability, which can impact the reliability and integrity of the data collected. In this webinar, we will delve into these complexities, exploring the nuance of reader variability and the strategies to address them. Our focus today will be on an application of robust reader monitoring plans designed to minimize data variability in clinical trials, employing imaging outcomes. Through these discussions, we aim to highlight best practice and practical insights that can help enhance precision of imaging assessment, ultimately leading to more reliable and trustworthy trial results. And if you're joining us live for the first time, you may also view our previously hosted webinars on our website at merit.com under the Resource tab. Select webinars to replay your on-demand webinar of choice. We also host these content on our company's YouTube channel. Please note we are recording these webinars so that it can be added to both our website, YouTube channel for replay. All attendees will be receiving a follow-up email with the link to this recording, which we welcome you to share with fellow colleagues and industry connections as you see it fit. All participants will be muted during the presentations. However, we will devote time into questions and the answers at the end. We invite and encourage you to submit the questions at any time throughout today's presentations via Zoom Q&A functionality. Our presenters will address as many questions live as time permits. All remaining questions will be answered directly via email following the webinar. And it is my pleasure to introduce our speaker for today's webinar, Dr. Lin. Since earning his medical doctorate degree, Dr. Lin has dedicated his career to exploring the invaluable role of radiology in clinical research. His extensive experience includes facilitating multiple sponsors and delivering high-quality independent reading data, which has been instrumental in securing regulatory approvals for various medical products across the numerous countries and regions. Currently serving as the Associate Medical Director at the Merit, Dr. Lin's work is characterized by his meticulous focus on protocol design, aiming to minimize risk and biases in clinical trials. His commitment to excellence is further evidenced by his vigorous quality monitoring of independent readings, ensuring the accuracy and reliability in imaging assessments. Dr. Lin's expertise in the field, coupled with his passion for advancing clinical research, makes him an invaluable asset for our webinar. And let's get into our introductions. For the introductions, I just wanted to point out a few clinical trial outcomes that can be driven by many different parameters, such as lab value, clinical assessment and scoring systems, and of course the imaging review as well. So some of these measurements are quantitative and some others can be more qualitative assessment. And at the end of the day, these predefined parameters, assessment and the measurement contributes to the final primary and secondary objectives and the endpoints of the clinical trial. It is very important that these assessment data are accurate and precise. As we talk more as an imaging review, there are various outcomes that are supported by the data that is driven from the reviewing the images. Such images are CT, MR, PET, X-ray, bone scans, and other radiographic modalities, especially when it comes to the oncology trial. Oftentimes, qualitative and quantitative assessment collected while reviewing these images will lead into the analysis of the objective response rate, progression-free survival using specific rules such as the tumor response criteria. This is the rendition of the prior slide into a little diagram, how images are interpreted based upon a tumor response criteria, and these values leads to deriving these outcomes. So basically, images are presented to the reviewer, then reviewer will identify all tumor burden of a subject, perform assessment to report for categorical outcome of complete response, partial response, stable, or the progressive disease. So basically, these four outcomes generally will serve as data to derive these common endpoints. And many of these radiographic modalities, such as CT, MR technology, has greatly advanced to produce a high-quality images in a non-invasive method to help assessing disease states of the patients. Still, image interpretations do involve subjectivity and interpretation of the morphology. So I wanted to bring up these two different concepts for Dr. Lin later on speaks about the reader monitoring plan and their specific parameters. First one is on intra-observer variability. Intra-observer variability is on variability that arises from a same reviewer assessing the same imaging studies or any assessment in a two different instances with the enough memory washout period. So basically, one reader reviews the images and we're presenting the same images later on to the same reader. And if there's a difference in result, that would be called the intra-reader variability. The other one is the inter-reader variability. This one is a variability that arises from a two different reviewer independently assessing a same image studies or assessment without a communicating between each others. Well, when actually that there is a variability in the same images between the two readers, that would be a variability that is arising from the inter-observer. And realizing these variability existing is very important because these variability plays its role in affecting the data quality in its own way. And it is very important because taking care of this intra-reader variability or intra helps the consistent result over the multiple evaluation of the scientific subjects, especially for oncology. We're performing a longitudinal assessment with the same disease type, having a similar presentations of the disease, if not all the same. So the consistency within the same reader over multiple different time points and a different subject is very important to provide the accurate and precise data. Also, in terms of inter-observer variability issues, is that there are a lot of multi-center trials, collaborative researches that has a large amount of subjects and time points, which we will need to use a multiple radiologists or readers in one study. And all the readers working in across the studies has to provide a comparable, the best quality result across the different reader, whoever reads the images within that study. So basically, we would want to achieve a consistent, precise result, and that result is accurate, that hits the target, just like the diagram over here. So that is the basically impact that can occur in the clinical trial outcomes, and it is important to take control of these variabilities during the studies. So there are various different sources of the variability that can arise in between. One thing is the fatigue can be an issue when reviewer reads images for extended period of time. This can decrease the tension level of the reviewer, increase the risk of error and a variability in their assessment. Sometimes experience with the response criteria rules or experience in a certain disease states may affect the variability of the readers. Inconsistent raw data collections, basically a CT or MR that is taken with a lot of artifacts or not being compliant to the imaging protocol can affect the reading quality and variability. Also, using incorrect way of using supportive tools or analysis method can also affect the variability, and also subjectivity of the nature of the assessment or complexity of the disease states also can be a factor as well. All right, and then source of variability can arise from specific design of the assessment as well. And I wanted to point out some of the response criteria, imaging modality related source of variability on next few slides. And the one for the RECIST is for the solid tumor assessment, which is a very common rules to assess the outcomes of each time point of the subject. There are several factors I just wanted to touch base. A few things is that at baseline, there may be lesions or tumors that seems equivocal or potentially seems to be benign lesions. These lesions may or may not be included in for the longitudinal follow-up. Those type of things can affect some differences across different readers. Also, when all tumor burdens are identified, reviewers may categorize a lesion into a different categories of the target or non-target in a different way. And of course, target is assessed with the measurement, non-target is assessed with the qualitative assessment by the reader per RECIST 1.1. And across the multiple time point longitudinal assessment, these variability can arise between the different reviewers as well. Also, perception of the non-target lesions getting worsening or any new lesion appearance can be perceived in difference across the reviewers. Especially some of the lesions may present with more of the diffuse patterns or unclear or irregular margins or the shapes. And I just wanted to pass a few of the images explanation for Dr. Lin here with the next few slides over here. Dr. Lin.
Yeah, thank you, Dr. Kim. It's sometimes not easy to understand why there is disagreement. Some of us may think it's only measuring a lesion. How can there be difference between readers or even readers themselves? So here is an example. This is a subject from a VEGF antibody and anti-vascular drug, non-small cell lung cancer study. Same reader measured the same lesion in the baseline left side and the follow-up visit right side. And the first row and the second row is within a 2-month interval. The reader select the same slice and measure in a similar way at the baseline visit, but not in the follow-up visit. In the follow-up visit, the reader measured in a different slice and different direction. In RECIST 1.1, we require that the measurement in the slice where the lesion shows the longest diameter. However, in some situations like the necrosis here, which is common for antivascular treatment, it's not always easy to decide where is the border of this lesion and which slice shows the longest diameter. And as you can see, even for same readers, they may come up with different results. Here's another situation, similar, but atelectasis this time. We can find the margin of the tumor lesion and the normal collapsed lung tissue by their different enhancement, but not always. Sometimes it's it's hard to know where's the border of this lesion. It will be painful if it happens in the follow-up visit because we will try every effort to measure the target lesion. But if it complicates with atelectasis, it's still a problem to decide where is the border. And this kind of lesion will often cause discrepancies. So no matter between local and central, or even with the central 2+1 pattern. One other common source of variability is the CT window, mediastinal or lung window. Although we have a rule that the reader are required to use the same window as the baseline, usually we won't restrict that at the baseline, the reader should choose the mediastinal window or the lung window. In fact, These two windows can show different treatment response. We can see that in the mediastinal window, the tumor regressed and then progressed. The response can be a PR, partial remission, followed by PD, progressive disease. In the long window, however, the tumor remains stable. The response is an SD and NSD. So picking different CT window can possibly result in different assessment. Okay, back to you, Dr. Kim.
Thank you so much for your explanation on the images, Dr. Lin. And then my next few slide is moving on to the different type from the RECIST. Another one is the RANO. It's used commonly in oncology studies to assess the response to the treatment in a primary brain cancers, such as a glioblastoma. Also, glioblastoma and other subtypes of the glioma has a very heterogeneous characteristics in their lesion presentations. Their growth patterns and margins can be very irregular, and this is a challenge for the readers with the variability. This presentation is very complex in nature. Definitely adds a factor of the variability in assessing the RANO. So choosing what qualifies the target lesion could be one of the factor. Measuring bidirectional measurement of the short and a long perpendicular axis, which is the guidance of the RANO, that would be another factor that can be performed in different manner. And I do have one slide of the images, for instance, on an image interpretation that occurs a little differently. And I would like to also have Dr. Lin quickly explain these images for us.
Sure. Now we know that in the RANO system, no matter RANO HGG, LGG, and 2.0, it used a bidimensional measurement instead of unit dimensional. So it means whatever that causes discrepancies in RECIST 1.1, it will happen twice in one RANO time point. And furthermore, RANO requires measuring the enhanced part. And this further increased the difficulty, like where is the longest diameter in the axial, sagittal, or chronoplanar? And does this measurement cross some part of necrosis? For this kind of irregular thick wall cyst, this is even harder. Yeah, back to you, Jim.
Thank you. Thank you very much, Dr. Lin. And also the Lugano classifications for the lymphoma or the posterior emission tomography for other types of radio tracer type of studies, there can be multiple different issues arising for the source of the variability. One thing for the main assessment type for the Lugano is the 5-point scale of the Dovo. So they would actually guide the readers to point out whether these hot lesions would be what scale depending on their intensity or the uptake on the images. So those type of scales can be one factor. Also, defining volume of the interest of the particular lesions through the PET scans is also another potential factors. Where is the margin or the contour should be really defined. Those type of the margin set is also another issues. And also for the PET imaging itself, many of the concurrent therapy or comorbidities that actually alters the metabolic activities can also increase the signal uptakes in the images that can mimic tumor or other presentations that can complicate the reading process, adding a variability and a confounder. So with these few factors of the source of the variability that we discussed earlier, how do we actually work on the risk mitigations and reducing the variability so that we can ensure there is a quality of data and a precision and accuracy is both ensured for our data? The first thing is a few operational aspects of these. Is the well-planned imaging protocol, which specifies the acquisition parameters that really fits for the assessment criteria and the disease states, and an image quality review of these images to prepare for the assessor or the reviewer is a very, very important, providing a best environment that reduces the risk of the unclear data review or questionable results. Also, another aspect is the semi-automated and assisted tools in the platform that behave consistent way in a precise way will reduce the variability in the assessment and also reduce the potential errors that can arise from the reader performance. Some disease states can be more complex, as we talked earlier with some of the cancer types like a glioma, and that's their complexity in the nature, and have more discrepancies in between the readers. In such cases, picking a right read paradigm that is being deployed in the study will also assist the data quality to be maximized. So such as the reading workflow of the to read with the adjudications oftentimes is deployed to make sure that if there's any discrepancy between the readers, that are corroborated by the third adjudication radiologist, for instance. And then also the reader training at the beginning of each study is very critical as well. Robust training on the guidance for the assessment and the specific charter documentations, the reading rule supports the reader with the less ambiguity, especially having a training image sets that are tailored to the specific disease assessment. With the complex cases will provide a better guidance for the on-study reading processes for the assessor. Also, training reader on a software tools and edit checks, supported features on a platform available so that they can actually maximize the platform usage is also another important aspect to mention. Detailed data review plan and a medical monitoring by the correct subject matter expert who does well understand these potential sources of the variability or pitfalls or errors that can arise from these data collection process or response criteria will also maximize the data quality control plan as well. And last but not the least, the reader monitor plan to assess the reader performance and a collaboration of the reader performance across the reader groups in a study is crucial, especially early assessment and on implementation of the reader monitor plan can lead to timely intervention to support the on-study reader to optimize the data quality for remaining duration of the study reads. For these reader monitoring plan and the details, I would like to pass my presentation back to Dr. Lin.
Thank you, Dr. Kim. This is my conflict of interest disclosure. And just as in the consistency evaluation of generic drugs, to measure the stability of a scoring system like RECIST, RANO, RANO, which involves the consistency of the evaluator, which is the reader to us, and the evaluation criteria, which is the tool, we also employ the reliability evaluation method to assess whether the overall evaluation system, including the evaluator, reader, use the criteria, is stable. So this is one of my research projects when I was a medical student. I evaluated whether a new optimized imaging acquisition sequence could produce better image quality than the traditional ones. So image quality evaluation is a subjective scoring process with categories like excellent, good, fair, and poor. While of course, we provide some scoring reference criteria, such as the clarity of the structural display and the presence of some artifacts. The control of the scales like clear structural display versus slightly unclear structural display. This can significantly impact the quality evaluation. And in such studies, if we are presenting this literature to editors, they will also pay close attention to whether evaluation system consistency assessment has been conducted. So one approach we can employ is to have the same reader use the same evaluation criteria to evaluate the same images and then compare the consistency before and after the evaluations. However, in the stage of radiology, there used to be a common saying that the radiologist may never met their patients face to face, but they can develop a very, very uncanny ability to remember specific cases. During consultations, they make you recognize the patient's CT and explain, oh, you are the patient with the heart-shaped lesion. And similarly, I can vividly recall the first patient enrolled in our sequence testing cohort and the unique appearance of their images. So while presenting the same images to those radiologists again, they might suspect that they have seen these images before. And this is a consistency analysis case. And they are being tested. So this can lead them to actively recall their previous evaluations, potentially influence their current assessments. So consequently, this analysis could lose its intended purpose. And this type of bias is known as recall bias. So apparently, the most effective method to eliminate the recall bias is to introduce an interval between initial and subsequent evaluations. By allowing a sufficient time gap, even the evaluator actively try to recall their previous assessment, it becomes increasingly difficult for them to remember the exact details. So some similar studies has been conducted in the field of pathology. Well, pathologists are also very amazing. They were presented with historical slides and asked them to record their previous evaluation of the slides after a 2-week or 4-week interval. They are known for their exceptional memory as well. However, the accuracy of their recall significantly decreased after 4 weeks compared to 2 weeks. Therefore, when we are dealing with those exceptionally perceptive medical professionals, it's very often challenging to completely eliminate their recall bias, but instead, we can employ memory fade methods to minimize this impact. So today we will discussing a crucial aspect of independent central reading in clinical trials, which is the variability read, and also known as consistency read, QC read, intra-reader variability analysis, whatever the name. These terms may vary across different vendors within our industry, and we need to pay attention that when we talk about consistency and variability, because these two terms are just opposite. Higher consistency means lower variability. Anyway, the primary goal of this stage is to conduct analysis and part of quality control. And throughout my presentation, I may use the term variability read to refer this process. The duration of memory fade interval we've just mentioned for variability read, it needs to balance the effectiveness of fade and with the practical of implementation. Theoretically, a longer memory fade duration would be ideal. However, this interval cannot be extended indefinitely. Clinical trials have a finite life cycle, and the time allowed for IRC review in a phase 3 trial typically can expand 2 or 3 years. It's impractical to extend the memory fade duration to such an extent. I've encountered some approach where variability evaluation and quality control are conducted at the late stage or even after the completion of image reads. This method allows for sufficient memory fade duration. It presents significant drawbacks, however. If If we identify inconsistency in the reader's performance during this variability analysis stage, there's no opportunity to rectify the situation. The efficacy reads are already complete, and there's little we can do about it if a reader's consistency is not optimal. Therefore, to assign a large number of variability evaluation, it can further increase the risk of the reader to become aware that this task is for variability read. Our goal is to maintain a blind evaluation, allow the readers to perform variability reads with memory-free fade and without being without consciously aware of it. So initiating variability read too early in this process also poses some challenges of insufficient data. Imagine if we were to blind and reassign the completed visit images of our still ongoing participants, and the reader might receive images from both the actual study and the variability read, increasing the risk of unblinding and compromising the integrity of variability evaluation. We typically schedule the variability read during the middle stage of the image read process, and by this time, a sufficient number of subjects have completed their studies and no longer require new image reads. And we can select a part of these cases of variability analysis, ensuring there will be an adequate case pool. And the interval between the initial and the variability reads is typically set as 4 to 6 weeks. And this approach can allow us to conduct a variability evaluation to identify potential issues and also make necessary adjustments, and simultaneously to bend the variability read cases into the reader's regular assessment task, maintaining the blind nature of this evaluation. So even if our audience today includes readers who are aware of our practice, it will be very difficult for you to identify variability read cases among the very large volume of regular tasks. And the ideal number of cases to use for variability read is not a one-size-fits-all answer. However, it's important to consider the cost and the statistical power of this evaluation. And these are the facts influencing case selection. For example, the study size. For smaller trials with few participants, a small number of cases may suffice, while large trials may acquire a larger sample size to ensure adequate statistical power. And also the criteria complexity. If the criteria is complex, a large number of cases may be needed to capture the variability in readers' performance, and also, of course, budget. The variability read will involve additional image reads. The reader needs to read again, which generate costs associated with reader fees and the data management. The number of cases should be balanced with the available budget for the trial. So here's our common practice. For example, the fixed number of cases. Some trials could employ a fixed number of cases, such as 5 or 10, regardless of the study size. This approach may be suitable for smaller trials or when the budget is tight. And for percentage-based selection, a more common approach is to select a percentage of cases for variability read, for example, a 10% selection rate. This could involve evaluating 40 to 50 cases for a 400 to 500 participant trial. This approach can ensure that the sample size scale with the study size and provides a more representative sample of the overall data. And another one is risk-based sampling. In some cases, the risk-based sampling can be employed where the cases are selected based on specific risk factors or characteristics that are associated with potential inconsistencies in evaluation. And this approach can focus the variability read effort on areas of higher risk. Okay, here is a summary of the requirements of selecting QC read task for variability assessment cases. Number one is completed cases. The selected cases should represent participants who have completed the trial and will no longer have new imaging data uploaded. And also number two, the memory fade interval. The selected cases should the variability read that can be conducted at least 4 to 6 weeks after the initial image is read to allow sufficient memory fade and minimize the influence of recall bias. And number three, the sample size. A sample size of approximately 10% of the total study population is recommended. Of course, this can be adjusted based on the budget consideration and the overall trial sample size. And the fourth one is the time point considerations. Well, there is no definite evidence-based guidance, but it's generally recommended to avoid selecting cases with a very limiting number of time points, like 2 or 3. And this also includes those cases with only baseline images and no follow-up scans, and also those cases with missing or not evaluable assessment in the initial efficacy evaluation. While selecting those cases with more comprehensive imaging data and complete assessment, they can provide a more robust basis of variability evaluation. And we need to select those cases that can represent the overall study population and make it blinded to the reader so that we can maintain the integrity and the variability read. And the assessment or assignment of variability read cases to reader should balance and unbiased to avoid systemic errors. Okay, now that we have selected cases and have the initial and the subsequent read result, we need to evaluate the consistency of read. Accuracy. Accuracy is the most straightforward measure of consistency. We can simply calculate the proportion of identical assessments between the initial and the variability read. And this approach is easy to understand and interpret. This will provide a very clear indication of overall agreement level. However, this method, its limitation lies in its inability to differentiate between common and the rare assessment categories. The kappa coefficient, however, it can address the limitation of accuracy by adjusting the expected level of agreement that occurred by chance alone, because it takes into account of the distribution of assessment categories and the penalized agreement that is merely due to chance. And this is how we calculate kappa. And here, the formula describes the unbalance, the PE, which describes the unbalance of the matrix on the left side. So for example, when one or two categories, such as partial response PR and the stable disease SD, they dominate the distribution. So this time, kappa will provide a more accurate representation of consistency. In example A, the distribution of assessment categories is balancing between PR, SD, and PD. And the difference between accuracy and the kappa we can see here is approximately 300th. However, in example B, where SD assessment are heavily concentrated, and this time kappa penalized the excessive agreement, resulting in an even lower value compared to accuracy. The difference is over 500. So in oncology trials, the assessment categories like PR and SD tends to be more common than PD and sometimes more common and even more common than PR. And this time kappa can provide a more meaningful measure of consistency. It will account for the uneven distribution of categories and reflects the true level of agreement beyond mere chance. And one other good thing about kappa is that after calculating kappa for variability read, the next step is to determine an acceptable passing score. There's no universally agreed upon threshold, but the statistical literature, they provide some guidelines for interpreting kappa values. The kappa values range from 0 to 1, with 0 indicating no agreement beyond chance and 1 representing perfect agreement. So statistically, kappa values are typically divided into these categories: poor, slight, fair, moderate, substantial, almost perfect, and perfect. And the passing score, they usually should strike a balance between maintain the rigor of the variability evaluation and also ensure that it is feasible to achieve. And setting an excessively high score may lead to unnecessary retraining or image rereads, while a score too low, while it may compromise the quality of the data. And establishing a passing score for variability read will require very careful consideration of the indication and, of course, our benchmarking data. In general, we will set the passing score for variability read at 0.4. And as we discussed earlier, the kappa coefficient is calculated based on the accuracy rate and further penalize the evaluation for its uneven distribution. So usually when the accuracy rate reaches 70% or higher, the resulting kappa coefficient will typically drops to around 0.5 due to the penalizing nature of this calculation. So for the perspective of our previous research, we always usually observe that most kappa coefficients fall between the range of 0.5 to 0.8. In the variability read, the choice of choosing kappa at the time point level or at a subject level, they can present a trade-off. So calculating kappa at the visit level, this could provide a more granular assessment of reader consistency across individual time points. And this approach can capture the finer details of agreement and potential discrepancies at each time point. However, it may lead to excessive focus on minor discrepancies and potentially diverting attention from study endpoints. And calculating kappa at a subject level, it will focus on the overall consistency of reader assessments for each subject across all time points. And this approach will consider the cumulative effect of assessments throughout the trial. It aligns with the primary interest in primary outcomes rather than individual visit discrepancies. But of course, it will provide less detailed information about consistency patterns across visit points. So the choice between time point level and the subject level kappa, it will depend on the specific goals and the priorities of the variability evaluation. And let's recall the slides we just discussed. We explore why we use the kappa statistics and how it differs from accuracy, how to interpret the kappa coefficient, the typical range of kappa values, and where to set the threshold. And additionally, we discussed whether we should choose the time point level kappa or the subject level kappa and the pros and the cons of each. And for this final part, let's talk about another method of using reader to manage other readers, which is the adjudication. But typically in our 2+1 setup, if the first two the initial readers, they have differing interpretations and the time point response. We bring in another reader, which is an adjudicator, to make a decision between reader 1 and the reader 2's results. And actually, we can have two parameters. The first one is the adjudication rate or the adjudication trigger rate. This rate can be assessed at a study level or the individual reader level. Anyway, this rate, the denominator is the total number of cases they evaluated, and the numerator is the number of cases that trigger adjudication. And the second parameter is the adjudication acceptance rate or adjudication agreement rate. Here, the denominator is the number of cases the reader trigger adjudication, and the numerator is the number of these cases where the adjudicator agreed with the reader. This table here illustrates these parameters. For example, the reader 1 reviewed 309 cases with 94 triggered adjudication. So here, resulting in an adjudication rate will be 30%. Among those 94 cases, the reader 1 has 43 were accepted by the adjudicator and 51 were not. So leading to an adjudication acceptance rate of 46%. Often we will say a high adjudication rate is not scary. What is scary is a reader that frequently being disagreed by the adjudicator. This is because the adjudication rate is actually influenced by many factors, including like tumor type, the criteria, or even the number of time points. And of course, I'm not making excuses. In the independent central reading section, factors like chart design, the reader training, and the capability of the medical monitoring system, these are also critical factors that the IRC vendors' medical resources that will impact the adjudication rate. The adjudication acceptance rate is theoretically trends towards 50%. So a significant deviation from 50% would suggest potential systemic bias. This reader may not fully grasp the evaluation criteria, or their criteria may be too lenient or too strict, which will require further intervention. So what constitutes a significant deviation from 50%? Is it 40% or 30% or 33%, like 1/3? Well, these numbers aren't arbitrarily decided. They are based on statistical analysis. The method I reference here is called P-chart analysis, PCA. And this approach actually originates from manufacturing for monitor product quality rates, particularly known as from the management strategy called Six Sigma. And the Six Sigma aims to control the defect rates within 3.4 per million, where the Six Sigma refers to the 6 standard deviation, which is 3 above and 3 below the mean in P-chart analysis. And how should we understand this P-chart analysis, PCA? We use the adjudication acceptance rate, AAR, to assess whether a reader has potential systemic bias. And if there is a significant deviation from 50%, it's similar to flipping a coin. If we flip a coin 10 times and got 4 heads, can we confidently say that the coin is unbalanced? Well, probably not. But because we recognize that this could be a random error due to the small sample size. And what if we flip the coin 100 times and get 40 heads? Well, this likelihood that the coin is fair decreases. And if we flip it 1,000 times and get 400 heads, we can be quite confident in rejecting the hypothesis that the coin is fair. But remember here, the adjudication acceptance rate, the AAR, is always 40% in all these cases. So therefore, the AAR must be considered in relation to the sample size, and the AAR threshold cannot be arbitrarily set to 1/3 or 30%. The sample size n, which is denominator in the AAR, is crucial. The smaller the sample size, the larger the standard deviation, which is the sigma, and the wider of the range, around 50%. And conversely, the larger the sample size will mean the smaller the sigma and the narrower of the range of 50%. Now look at the top right of the chart. The green line, which is the warning limit, corresponds to 2 sigma, and the red line, the action limit, corresponds to 3 sigma. And these lines have varying widths, reflecting the varying number of cases trigger adjudication for different readers. And these lines, the warning limit and action limit, are what we can monitor in real time during reading process. If a reader performance falls below these lines, it will signal the point at which the IRC medical teams needs to demonstrate their expertise and take appropriate action. And finally, I have a take-home message for everyone. Well, today we discussed 2 methods, variability assessment and the PCA. If we consider the evaluation criteria as a ruler and a reader as the people using this ruler, then the consistency analysis variability read compares whether the measurements taken with the ruler at different times are the same. Well, however, it's possible for readers to make the same mistakes consistently and leading to high consistency even if they're wrong. And PCA, on the other hand, can identify outliers. If someone used the ruler differently from others, PCA will highlight this person. However, this person might actually be correct, while everyone else is making the same error. And using readers to manage readers cannot address systemic issues with the system itself. It's like trying to lift someone by pulling his own hair or attempting to climb the step on one foot with the other. It's an inherent limitation of this approach. So how can we assess if the readers are using the ruler correctly and accurately applying the evaluation criteria? We won't delve into that question today. Instead, I will leave you with this question as we transition into our next segment. Back to you, Dr. Kim.
Thank you so much, Dr. Lin, for the excellent overview of the variability in a reading process and a reader monitoring plan. I really appreciate your time. Just to remind our attendees, you can always go to the Merit website to check our webinars on the other reading criteria such as RECIST 1.1, RANO, PCWG3, and so on. And we have reached our Q&A portion of our presentations. If you have any questions, please submit them now via the Q&A functionality in Zoom. While you're sharing your questions, I would like to share 2 slides to introduce you to the Merit. You may know the Merit from our many years of the managing clinical trial in ophthalmology. We have served biotech and pharmaceutical companies in their clinical endpoint analysis for over 10 years with a team of medical professionals and seasoned operational support staff. We offer support to our partners in a variety of therapeutic areas, including oncology and respiratory. We are based out of the Madison, Wisconsin in the United States, but our company has a global reach. We have a team, members, and reading centers around the globe, making it possible to support sites and sponsors from a variety of locations. Myriad is more than an imaging service provider. We're positioned to be an extension of your study team. Our approach is to focus on the 3 areas. Our software system, Excelsior, can handle all aspects of an imaging core lab in one system. from acquiring images from a study site to performing an independent read and a transferring data to a sponsor. Excelsior can manage and track images every step of the way. Myriad has a large network of over 300 radiologists and oncologists to help support studies in a variety of therapeutic areas. Finally, at Myriad, we value a partner approach, working closely with our sponsors and sites to build a trust, partnership, and long-term relationships. And our proprietary software platform, Excelsior, delivers automation in a single system for all images and workflow management, resulting in a clean, complete, and accurate data that will meet your clinical trial needs. Excelsior has been used in over 200 clinical trials and is validated and an FDA 510(k) cleared medical device. Our unique role-based software allows all key stakeholders to work within a one platform, regardless of the location. This is so exciting because all data is housed within one system. The images, workflow tracking, queries, and read assessment data. It avoids the need for not multiple systems to be configured to talk to each other. So we'll now open the discussion for any questions that you may have. All right. So I do have one question here. For kappa, it seems like this measure assumes that there will be a variability. However, with certain trials, you have a limited set of types. How do you deal with this? Can I direct this question to Dr. Lin?
Yes. Thank you for this question. So kappa analysis actually it is for the what we call the characterized variables. So usually in the oncology studies, the reason that we frequently use kappa is that we have certain categories like the complete remission, partial remission, stable disease, etc. So by this categorized variables, we can calculate kappa because kappa is actually based on those variables that is not continuous. But for some other clinical trials, I believe there will be some variables or endpoints that is based on some continuous measurements, for example, the scale or the area or the volume, etc. So for this kind of endpoints or measurements, at this point, the kappa will not be appropriate because it is not for this situation. However, we can still try to catch whether the reader, for example, the initial read and after 4 to 6 weeks to allow the reader to measure them again. But for those continuous variables, we will use another method called the Bland-Altman plot, where we can find the also a very statistical method to find the mean and also the standard deviation of different plot, and there will be another 95% confident interval to decide whether there will be any plot that deviate from this range, and this will also to support the fact that the reader can consistently measure those continuous endpoints of your clinical study.
Thank you very much, Dr. Lin. And I do have another quick questions. Thank you. And how does the reading software platform helps managing the variability in a read? I can probably answer this questions for the audience here. So the reading software platform, it provides a standardized and consistent workflow and also response criteria edit checks. It also helps to prevent the reader from making the mistakes or errors at the reading processes. So also the reading platform that has a good configurability that ensures the proper and a robust ECRF design that really fits the study to collect the data complete and accurate. Also, there is a semi-automated outcome calculations and tools that will support the outcome calculation that is really consistent across the radiologists that is being participated in the studies to ensure that the data accuracy is also ensured. Um, Moreover, sometimes reviewing the imaging time between the visits may affect the reader with the biases, and a reading platform will support these type of reading environment to be as unbiased as possible, to reduce the variability that can arise from the information that can affect the reader bias. So all these factors really are played into a considerations when designing these reading software platform, and thus provide the optimized environment for the radiologist to perform and do their job at its best. Looks like I have another questions. This may be our one last question for the time being. What are some other common challenges you might have encountered when implementing the reader monitoring plans? What are the ways you have addressed them? Can I pass this on to Dr. Lin for the answer?
Sure. Yeah, very good question. Well, I think the biggest challenge actually is the plan, because the reader monitoring plan, well, I can say that in almost in every vendor there is a reader monitoring section that no matter in a charter or in the other documents, they will outline the process of, for example, the variability reads or sometimes the adjudication monitor. But the problem is, for example, when should we do this? In what what is the time point, and after how many percentage of the time points has completed should we do this? So if we do not have a plan in advance, I believe that most of our audience have known that in the new version of GCP there is always a saying that the quality by design. So this design will be very crucial for our quality monitoring. So in our reader monitoring plan, we have a very detailed schedule of when should we do our inter and intra variability assessment, and for this PCA in after how many percentage of time points have completed should we look into this. And of course the plan should always outline the next step action should we take if the reader some performance parameters fall below the passing score, and what should we do? For example, retraining, and how many times retraining do we allow, like 1 time or 2 times, and then we have to replace this reader. This has to be in the plan. So I think this will be the most challenging part.
Okay. Thank you very much for your insight and the answer, Dr. Lin.
Sure.
Okay. And now we have reached the end of our Q&A sessions. And thank you once again for your time today. You can stay up to date on additional primary endpoint related content by following our company page on LinkedIn. Please stay tuned for the more information regarding Merit's upcoming webinars, and have a great day. Thank you.